Doctor, we are live.
Good evening, everyone. At the outset, I welcome all of you to the Symposia on Retinal Pathologies being organized by the Eye Surgeon Society of Karnal. And today we are very lucky to have eminent speakers from institutes of national and international repute. Firstly, I welcome Dr. Rajiv Raman. He is a senior consultant at the Department of Vitrectomy Services, Shankar Netralaya, Chennai. He is also visiting faculty to the Vision and Eye Research Unit, Angela Ruskin University, Cambridge, and Dr. NTR University of Health Sciences, Vijayawada. He is also visiting faculty to BITS Pilani and Chitkara University, Chandigarh. Dr. Rajiv Raman, he has more than 250 publications in peer-reviewed journals and 14 chapters, including a chapter on diabetic retinopathy in the prestigious Ryan's textbook of Retinal. He has won the Asia Arvo Young Investigator Award, the Ruby Bannock Memorial Award for the Best Researcher at Shankar Netralaya, Chennai, Dr. T.L.K. Rome Memorial Endowment Award, and the C.N. Shroff Award from at the All India Ophthalmic Society in 2019. Sir, it's a privilege for us to have you amongst us, and I would like to start the session with your presentation. Over to you, sir.
Thank you. Thank you. It's a real pleasure being in this meeting, and such a nice meeting arranged and very good program. And I hope this session, all the listeners will really benefit. Uh, Let me share my slides and then let's see whether, can you see the slides?
Yes, sir. They're visible.
Yeah. So 1 minute, I'll just reduce this. So next couple of minutes, I'll be sharing some thoughts on Brolucizumab in the management of neovascular AMD. And today we know that it is available in our country, and how we can translate the evidence which is there currently about this drug into our clinical practice. So in the management of neovascular AMD, there are a lot of anti-VEGFs already in the market, and many players are there, and you have one new agent which we can use. So just to compile all of them, Avastin has been there for long. There is always this fear of endophthalmitis, off-label use, but still in many parts of the country, it has been used. We have ranibizumab, again by Novartis, very good, robust evidences. I think no other anti-VEGF has such robust evidence as ranibizumab. And they also have India-centric special costing, which is there with this drug. We also have biosimilar, though there were initial fears of inflammation, but over a period of time, it is one of the good alternative for ranibizumab, but however, more in practical sense, people use it as an alternative of Avastin. We have aflibercept, very good evidences now on the the efficacy of this drug in neovascular AMD. However, cost of treatment is a limiting factor. It has definitely found a place in treating fibrovascular PEDs and polypoidal disease in our country. PDT still has a place in managing PCV. However, with time, now currently the problem is availability of PDT because only few machines across the country, and cost is also an issue. The treatment strategies have evolved over time, and now the standard treatment regime, which has good evidence that it seems to be good, is treat and extend way of treating AMD, which actually means that you increase the follow-up by 2 weeks. So you start injecting, and after your initial injections, if you feel that there is no disease activity, you can extend the treatment by 2 more weeks, but you inject that visit. And you can increase every time like this 2 weeks till a maximum of 3 months. And if there is no disease activity, if there is a disease activity, you reduce the treatment interval by 2 weeks. This seems to be a good treatment method, and it has definitely, the efficacy seems to be similar to the monthly treatment regime. Less number of injections, definitely better disease control, and seems that this also has less cost. However, when we start treating our AMD patients in real life, many a times we do want to follow evidence-based medicine, and we start with treat and extend. And after some time, we know that our patients, they don't want injection at each visit. And then we switch to what is called as PRN, where you do tend to tell the patient that better to come every month, but we'll inject whenever there is activity. And after some time, he is tired coming every month also. And that time you switch to wait and extend. You call every time 2 or 3 weeks later, and you extend your follow-up, and even you don't treat. And if you assume there is a neovascular AMD who had 3 intravitreal injections and disease activity totally subsided, and you follow treat and extend, you will be giving 7 injections in a year, and you will have 7 visits in a year. You follow PRN regime, you'll have 3 injections in a year, but you'll have 12 visits in that year. And if you are following wait and extend, you'll have 3 injections and 7 visits. Though you feel that do the PRN and wait and extend seems to be better as far as patient pocket is concerned, but we know that by reducing the number of visits, there is a chance of missing a activity. And if we reduce the number of injections, there is suboptimal outcome. And it's not only our country, this is the real-time data of nearly many of the European countries, where we do see that initially with good number of injections, there is a good improvement. And then the treatment effect, the benefit in terms of best corrected visual acuity seems to reduce over a period of 2 years. And the reasons are these: the number of visits and the number of injections. Long-term outcome, what we are looking at is ideally no membrane. However, many times when you tend to undertreat, you get fibrosis. And when you tend to overtreat, you get atrophy. So we don't want these things. We want a good outcome. And the big question is that who decides which treatment regime and which drug to be used in a patient of neovascular AMD? It's actually the patient who decides. And the problem is the decision is dependent on many factors: the awareness about disease, of the realistic expectation of the treatment, the cost of visits, other comorbidities, family support, fear of travel in these COVID times, the fear of injection itself. And one bad experience of an injection usually puts off the patient for the next injection. So there are a lot of factors which determine, and as I told you, it is the patient who decides what to be given. Uh, as ophthalmologists, we do know, and we have learned from over a period of time, that the disease activity is dependent on presence of fluids in each compartment. It may be subretinal fluid or an intraretinal fluid or a sub-RPE fluid. And however, this concept has come more recently, though we were looking for residual fluids. But if you look at all the landmark trials, Anchor, Marina, View, CAT, and Ivan trials, they all speak about reduction in the central subfield thickness. They don't talk about these fluid, that how much of each fluid has gone. And that's because all these studies had actually used a time domain OCT. And we know time domain OCT has lower resolution, radial scans, interpolated data, no registration. And yes, they did tell that there is residual fluid, and those who have these fluid, they have poor outcome, but they never compartmentalize these fluids, which whether it is intraretinal or subretinal. And we know that the current OCTs, the SD OCTs, and better OCT, the SWEP source, they have better resolution, and they can actually, we can look into the fluid in a more closer view. And there are 3 studies which actually looked into, which used spectral domain OCT: the Harbor study, the Hawk and Harrier, and Cedar and Symposia study. They were for Ebesipar, the middle ones were for Brolucizumab, and Harbor was for 2 doses of ranibizumab. And these are the studies which actually had used spectral domain OCT. So, and we get a lot of information about the fluids from these 3 studies. So what is bad as far as CNVMs are concerned? As we saw residual fluid, we saw the thickness changes, but many of the studies have shown it is the central subfield thickness variability which is very important. And mainly, if you look at cat Ivan, there were two studies, and then you had the hawk and harrier. Both studies showed that if a patient has a lot of fluctuations in this central subfield thickness, they are the people who have worse BCVA. So this seems to be a uniform parameter as far as the BCVA improvement in treatment of neovascular AMD is concerned. The Harbor study, post hoc analysis, and even now the fluid study, it did show that they tried analyzing the fluids because they had used the spectral domain OCT, and they did find that those who have only intraretinal fluid seems to be the worst one in terms of best corrected visual acuity. In these studies, there was some protection, they said, with SRF, but I'll not go into this SRF debate. But definitely, these are the studies which did tell us that these fluids are more important rather than looking at only the thickness. So we have a couple of unmet needs in neovascular AMD. We want less injections, less visits, and definitely less residual fluid and less central subfield thickness fluctuation. And in 2019-20, there were two drugs which came. One was Brolucizumab and another was from Allergan Abicipar, and both were submitted to FDA for approval. And Brolucizumab got approval on October 2019. Abicipar, however, had little more inflammations. That's the reason why this drug was not approved by FDA. Now, just telling about this molecule, this is a structure I'm sure many of you, we all are familiar with, a full-length antibody, and it has got two Fab fragment and one FC domain. And of them, the colored ones which you see, the variable domains, are the ones which binds with anti-VEGF. And more so, if you look at those dots which are there, they are called as CDR, complementary related region. That's a specific site where it binds with anti-VEGF. And what Novartis actually did, they created some novel CDRs, and they had a small protein, a proprietary scaffold protein. They joined both of them and came out with this molecule, which is a little smaller molecule, a 26 kilodalton molecule called as Brolucizumab. Now, there are some key characteristics of this molecule. Being smaller in size, we do expect that there'll be more drug in a single injection. It causes more potent inhibition of VEGF-A. And being smaller in size, it has got a very effective penetration of the retina and choroid. And it has got a rapid systemic clearance, again, because of the smaller size. The studies which gave the approval, the FDA approval, was based on these two trials, the Hawk and Harrier study. They were conducted at different geographic locations. And Hawk had three arms, a 3 milligram, 6 milligram of brolucizumab, and aflibercept, which is again a standard of care. And the Harrier had only 6 milligram and aflibercept. So if you look at the design, initially there were 3 loading doses which were given for both. And then we know that when we start on Eylea, we increase the follow-up by 2 monthly injections. So after 2 months of the third loading dose, the patients are seen again. And if it was in a aflibercept arm, the intravitreal injection of Eylea was given. But if it was in a brolucizumab arm, there was an option. They tried looking at disease activity. If the disease activity was absent, it was increased to 1 more month, and third month the injection was given. And if the disease activity was present, the injection was given at 2 months. And then thereafter, every 2 months, the injection was given in this arm. And there were fixed time points where the disease activity was assessed. So effectively, what it means is that you had group of patients of brolucizumab who were on 3 monthly injection rather than 2 monthly injection. And this was basically a non-inferiority trial. That means they wanted to look at whether it is similar to aflibercept. And this is the results as far as BCVA is concerned. So 16th week is the first time point. So 3 loading dose given, and 2 months later the patients came. And that's the time, if you look at both in Hawk and Harrier, results were very much similar as far as brolucizumab and aflibercept was concerned. The primary endpoint, again, the results were similar. And even at the secondary endpoint, brolucizumab was non-inferior to aflibercept 2 milligram. And as far as central subfield thickness is concerned, definitely you can see the line, the blue line, which is for brolucizumab. What you can appreciate is aflibercept is showing a lot of spikes, meaning this is what we don't want, because these are the variations in the central subfield thickness, which I told is bad. And what you can see is brolucizumab is more or less straight line, and there's a significant difference as far as the drying of brolucizumab is concerned as compared to Eylea. They tried looking at what type of fluids were reduced. So if you look at intraretinal fluid or subretinal fluid, even at 16th week, that is just with these 3 injections, those who were on brolucizumab had nearly a third more drying as compared to those with aflibercept. Same was true at each 1 year and 2 year follow-up for both intraretinal and subretinal fluid. Also with sub-RP fluid, which we know is sometimes difficult to treat. Even in the initial arm, nearly 30% of them, 30 to 33% of them had dried subretinal sub-RP fluid. This is the comparison at each point of absence of all the fluids. Dr. Ursula tried looking at a little more details of these fluids. She used an AI algorithm to detect these fluids. So you can see this is the manual, and this is how in the AI algorithm she could detect these fluids. And she could actually measure these fluids in nanoliters. And she divided the whole group, the Hawk and Harrier population, into those who had high fluids versus low fluids. And she did see that those who had these lower levels of fluid, maybe intraretinal, subretinal, or PED, they had better visual outcomes as compared to those who had residual fluids. So definitely intravitreal brolucizumab seems to have a better drying effect than Eylea. And just looking at how they defined the activity, so they used both anatomical criteria and functional criteria. The function was based on vision improvement, and presence of fluid or a reduction in or increase in the thickness was considered as disease activity. And if you look at the disease activities which were assessed in both the studies, majority of that, it is the anatomical outcome. So even in practical, when we treat our patients, we don't rely alone on vision, but we need to look for functional, the anatomical markers, which are more important to determine the disease activity. They also did some probability analysis, and what they found that people who were treated with brolucizumab 6 milligrams, uh, they maintain 3-monthly interval for 1 year. Nearly about 50 to 60% of them will have 3-monthly injections. You don't have to reduce uh, the interval from 3 months to 2 months. And if a patient successfully completed the first 3 loading doses, and the first one was by 3 months later, very high likelihood, nearly 85% of them will continue to be this 3-monthly interval for the first year. That means that after loading dose in year 1, only 1 or 2 out of 10 will need more than 3 injections. Majority will be just these 3 injections which are there at 3-monthly interval. They also tried looking at 2 years outcome, and they looked into that if a person is with 6 milligram brolucizumab, what is the chance that till 2 years he will be on this 3-monthly interval? And that's about 40 to 45%. And if he completed the first year with this 3-monthly interval, not to reduce by 2-monthly, nearly more than 80% of them will continue to be on a 3-monthly regime even in the year 2. Again, what it means that in year 2, 8 of 10 will need just 3 injections. So definitely it does reduce the number of injections. So there is less need for injection, and there is a more drying effect as far as brolucizumab is concerned. The Hawk and Harrier study came out with some ocular safety profile, and you can see here they did see some inflammations, even retinal artery occlusion, endophthalmitis, and there was a post-marketing update by Novartis to keep a watch on these symptoms. So I tried doing a critical appraisal of this Hawk and Harrier study. There were some points, mainly like there were some, mainly with Harrier study, arm of the study, more than 3 months disease duration and more patients with baseline SRF was there in the Eylea group. That shows that these are more chronic cases. You don't expect much improvement. There was also risk of unmasking the treatment assignment because the injector was unmasked. He knew what he is giving. That might have a bias as far as results are concerned. And in this study, there were only treatment naive eyes, and we do know that in our clinical practice, we do see patients who had multiple other injections. There was no comparison with Avastin or Lucentis, which is commonly used, and it didn't check the most common and regime which we use, that is the treat and extend regime. And when they went to FDA for approval, there was a little change in the formulation of what was asked for approval and what was used in Hawk and Harrier. So the FDA asked them to do another 6 months follow-up study. And these are the results from the follow-up study of Hawk extension study, which also showed that the benefit was continuing even in these 6 months. And based on these extension and Hawk and Harrier, Brolucizumab got approval. Thereafter, that is after October 2019, there are a lot of real world evidences, and this is the one of the study, the Bruce study published by Dr. Kaiser's group, had about 42 patients, 60 injections, and in this real-time experience, they used patients who were previously treated with other anti-VEGFs, and they showed a good response in visual outcome. There was less disease activity, and in this series, they didn't find any inflammations. So what happens in the real world? So on February 23rd, there were 11 cases of occlusive vasculitis, and in March 30th, there were 21 cases. And we all knew during lockdown, we heard that there is a ASRS alert about this drug as far as use in neovascular AMD is concerned. And after that, there are several reports which have been published related to intraocular inflammation. Some key points are that majority of these inflammations occur within a month of injection, more so about 2 weeks is the period. It can happen both in treatment naive and previously treated group. And 75% of them within 6 months, the inflammation is there. So again, it's not like only 1 month, it can go to 6 months. And the sad part is that 1/3 of them, they lose vision. So I think this is something we need to keep in mind. And Novartis proactively went ahead establishing a safety review committee, which had ophthalmologists, retina and imaging specialists, UVA specialists, and they tried looking at four points. What is the root cause of these events? How can we characterize a patient who will have a high risk of developing inflammations? What can we do to mitigate the incidence? And if somebody develops these inflammations, what should be done to treat it? And the think tank, this committee has come out with one report, how to treat these inflammations, which have been published now. And I'm sure with time, we'll get more knowledge about how to get rid of these inflammations. So as per Novartis post-marketing data, the incidence of these adverse effect of intraocular inflammation is nearly 10 in 10,000, meaning 1 in 1,000 patients injection. So I think this is something you need to definitely keep in mind. So what pre-injection considerations you should keep? Definitely don't inject if there is any inflammation. Look for anterior chamber and vitreous cells and flare, any features of old uveitis, both anterior segment or posterior segment, healed or active uveitis. Take a prior history of inflammation following injections, tend to avoid in them. And in the initial experience, it would be good idea to avoid any one-eyed patients. Investigations, definitely do a thorough indirect ophthalmoscopy, and if you have a wide field retinal photography, good to take that. And definitely look for a healed or an active vasculitis or uveitis in the posterior chamber. In OCT, besides looking at your membrane fluids, also try to look for vitreous cells, because these may be, again, these are the features which suggest inflammation, and you should tend to avoid giving in these patients. The risk of 1 in 1,000 getting inflammation should be there in your consent form, and definitely you should tell them this to the patient. And more important, you should document all these negative findings also in your case record, and alert the patients of the symptoms. If they have floaters, pain, pressure, ocular discomfort, which is persisting for more than 2 days, you have to actually educate them what the floaters are and how to look for it. They should look at a white background or no, a wall with a light, and see that whether they see any floaters. Whenever they have excessive light sensitivity or they prefer goggles wearing, that is something, again, it should alert the patient. Or if they have a reduced vision or vision loss, and when they come to you, look for intraocular inflammation, vasculitis, or any vascular occlusive event. So this is the mitigation plan which have been published now in ophthalmology retina and also presented at Retina. The key is give steroids in all forms. So even IV methylprednisolone has been given. And the second key is keep a low threshold for wide field fundus fluorescein angiogram. If you have a doubt, many times even in the hazy media, you can get to know the involvement of arterioles and venules. Some key clinical features of brolucizumab associated inflammation is Witt cells, vitreous opacities. Anterior segment, you can get non-granulomatous KPs, corneal edema. It can affect both arteries and veins, and you can get varying level of artery involvement, a small or a large caliber vessels, narrowing or occlusion. You can get sheathing. It can involve posterior pole or the peripheral vessels. Also, you should look for signs of ischemia on OCT. And retinal vein, again, it can be dilatation, narrowing, or a typical vein occlusive picture you can get. Sometimes they can present with optic nerve swelling. So now the big question comes whether you should inject this drug or not. I think you need to put this in perspective. The center round is actually the same size. That is the risk of intraocular inflammation. It's the way you look at benefit. If you feel that in some of your patients it will benefit, you see that circle as a big, automatically the risk circle seems to be smaller. And the moment you perceive this benefit small, the risk seems to be big. And that's something you need to keep into mind when you start using this drug. So definitely brolucizumab has answered a couple of these questions. There is less injection, less visits, there is less residual fluid, and definitely less fluctuation. It has answered a couple of these unmet needs. And this all has been because of the attributes of brolucizumab: the smaller molecule, greater reductions of CST, a 3-monthly regime, better drying effect. So it has addressed all these unmet needs. And now it is approved in India as Pegenex. This is the market rate, and good thing is they have come out with a special pricing for India, and that brolucizumab definitely represents an important treatment option for patients with neovascular AMD. Thank you very much. I'll be happy to take any questions.
Thank you, sir. Sir, we have requested for the questions to be posted in the chat box, and we'll take them up at the end of the session.
Sure.
And sir, I'll thank you for your intellectual inputs. And sir, I'll invite Dr. Aditya Sudhalkar to sir present his real-world experience using the drug. And may I request Dr. Rohit to kindly introduce Dr. Aditya?
Good evening. Welcome, Dr. Aditya Sudhalkar. Dr. Sudhalkar is a well-known retinologist in Baroda. He is a visiting doctor and researcher in Germany. He has more than 30 publications to his credit and is one of the first users of brolucizumab. Thank you, Dr. Aditya, for joining this session. I request you to please begin your session.
Yeah. Sir, thank you very much for a very kind introduction and a very good evening to all. Thank you for inviting me for this talk, and I look forward to the other talks as well. They're very informative. So without further ado, I'll just go ahead with our presentation. This is just our clinic in Germany, and this is our director. I just want to state that I have full rights over the data that will be presented here. That is our German data. And I'll also be sharing a case from India that we've injected, amongst the first in India. So our first case is a 74-year-old retired physician from Germany, Bremen, who presented to us with metamorphopsia since 4 days and diminished reading ability. So the left eye vision was affected, and except for pseudophakia, there was nothing remarkable about the anterior segment examination. So the fundus photograph and the angiography is more or less suggestive of, a very evident CNVM. And now, just to give everybody a heads up, in Germany, the protocol is that you give 6 monthly injections of whatever drug you choose. Aflibercept is currently the standard of care, which means that you give for 6 months, you're injecting 6 units of aflibercept. And then you assess the patient at 6 months. So let's say he has a dry macula, you extend the treatment interval by 2 weeks, that is up to, instead of 4 weeks, you make it 6 weeks. And then if it stays dry after the 6-week injection, it goes on to 8 weeks and then 10, and then eventually up to 12. Now, with the publication of the Altair study, currently it is permitted to use 4 weekly spurts instead of 2 weekly spurts. And secondly, we can extend it up to 16 weeks, which means that effectively the patient has 3 injections per year. So in this case, unfortunately, we could not extend therapy even by 2 weeks because the patient continued to actually worsen despite regular follow-ups. So first he received 6 injections of aflibercept and then 6 injections of ranibizumab, and it still continued to get worse. Finally, we were able to switch him to brolucizumab in March. And this is after the first brolucizumab injection. As you can see, good resolution of the fluid and everything. The PED has started to flatten. And by the second, it was quite okay. So Dr. Raman sir, he mentioned about resolution of disease. And that is what ultimately we are aiming for. Now, at the 8-week visit, the macula was dry. But at the 12-week visit, we can see this little growth back here. So he received his fourth injection at 12 weeks. And then since then, he has been doing fine. Our second patient is a 78-year-old lady who belongs to a religious subgroup that actually goes to people and reads the Bible with them. So she came to us with a complaint of missing letters in the Bible. So on examination, the vision was not significantly affected, but it was affecting her reading abilities. And except for early cataract, there was really nothing significant about her anterior segment examination. Now, in this case, as opposed to the first case, the clinical picture and the angiography actually leaves room for doubt whether there really is a significant CNVM, although the PED and all is suggestive. And then, yes, we see certain cysts here. And normally, perhaps in India, we would not really, the patient would not be convinced for therapy. But in Germany, it's a different story. They are all, they all have universal health care. They can have as many injections as they want. And she wanted treatment. So she underwent the 3 mandatory injections as recommended. And she's doing fine. She's yet to receive her 4th injection. Excuse me. So this is what she has received. So case number 3 is again a 69-year-old Arab refugee from Germany who presented to us with metamorphopsia and inability to read the Quran since 1 month. So she had significantly affected vision. And in this case, the CNVM was, quite evident. So here what we see is that the CNVM after the first injection itself showed significantly reduced activity. And after the second injection, it was resolved completely. So she received 3 monthly injections, and then, as always, as is mandatory in Germany, after the 12 weeks, she receives her 4th injection. So if we see, we have now 30 patients with a 6-month follow-up. 12 of those are treatment naive, and 18 of them are switch patients. So the findings are more or less in line with what we would expect with brolucizumab. But the main thing is we are yet to see any complications. So no inflammation, no vasculitis, nothing. Here what we have done is put up the number of patients who showed resolved intraretinal fluid, subretinal fluid, and sub-RPE fluid after one injection. And eventually, out of the 14 patients who had received this thing, it resolved in 13 of those. Now, coming to our local case, there was a 65-year-old, this was a 65-year-old male who presented to us in April 2017 with a complaint of metamorphopsia since 15 days. He had recently had cataract surgery, and although his vision was 6/9 and 6, his amsler was positive, and his angiography, OCT, and OCT angio had been done elsewhere. So I apologize for the poor quality of the images, because these are scanned images. Now, what is interesting in this patient is that the right eye also has some evidence of disease activity. So what we see here, this is the right eye, and what we see here is that there is waxing and waning subretinal fluid here in the right eye, which has, well, he's asymptomatic. So in the past 3 years, we have not administered any therapy for the right eye. But for the left eye, what we see is that despite receiving a sizable number of injections, the disease has continued to worsen. So whatever is happening is in between, the disc and the fovea. So what we see is that he has received around 17 or 18 Eylea injections, 4 or 5 Accentrics or ranibizumab injections, 2 or 3 biosimilar injections, and Avastin. But he continued to worsen. Now, keeping in mind that this was exacerbated by the cataract surgery, we had advised him concomitant steroids from the word go. But he was a diabetic, so he refused systemic steroids. And then local steroids, he was apprehensive of IOP spikes. So ultimately, what did work in this patient was a combination of aflibercept and Ozurdex. And you can see the implant in situ here. However, 6 weeks after this combination therapy, we were back to where we started. And that at this point in time, we injected Brolucizumab because by then it had become available in India. And this is the 1 week follow-up. Now, he was supposed to come for a 1 month follow-up on the 3rd. But in the interim, he has developed respiratory symptoms and they're suspecting corona. So obviously, we said that there's no need to follow. However, this is from the 1 week follow-up visit. And this is his photograph. So obviously we did an indirect ophthalmic examination and we have ruled out vasculitic changes. Now, telephonically, the patient is doing quite well. He says he reports improvement in vision. However, having said that, his vision has actually never progressed beyond 636 N12. So we hope that perhaps with the second injection we can give him some better vision. So thank you very much for your attention. And as Raman said, we would be happy to take questions at the end of the session.
Yeah, thank you, sir, for excellent case presentations.
Thank you, sir.
Great collection. And the best thing was that you were crisp and to the point. Great learning, sir, presentation. Now I would request Dr. Adviti to kindly introduce the next speaker, Dr. Rajesh from Bangalore. Adviti, ma'am, please. Dr. Adviti? Dr. Adviti Aroda? Okay, I think ma'am is not audible. So Rajesh,
can you hear me now?
Yes, ma'am. Ma'am, we're waiting for you.
Yeah. A very good evening to all of you. Should I start?
Yes, ma'am.
I'm audible? Yes. It's my great honor and pleasure to introduce Dr. Rajesh, Consultant Vitreoretina Services at Shankar Eye Foundation. Dr. Rajesh is an alumnus of Bangalore Medical College. He did his post-graduation from RP Center, Delhi. He has a special interest in vitreoretinal diseases. He is a very active member academically with 46 peer-reviewed articles till date. And he is also one of the co-organizers of the prestigious RetNet meet. We welcome you, sir, and we are obliged to have you here on this platform. Over to you, sir.
Thank you, sir. And thank you, madam, for the kind introduction. It's an honor and privilege to be a part of this presentation. So without wasting much time, I'll go into my topic, which is complex diabetic retinal detachments. So clear logical solutions. I'll give some amount of tips and clues how I deal with these cases on a daily basis. So before I jump into the cases per se, let me go into the summary of indications. Diabetic vitrectomy is indicated um, in cases such as where we have a media opacity. If a patient has a severe non-clearing vitreous hemorrhage, which might be either vitreous, subhyaloid, or a premacular hemorrhage. If there is tractional components and detachments of the retina, which include a taut hyaloid or an EMM, which makes the macular edema non-resolving to the standard care of treatment, which includes anti-VEGF and laser. Threatening or involving macula, TRD involving the disc or PMB, these have been indicated in the recent times, and combined mechanism of retinal detachments, which causes a regma break along with a tractional component. If there is a ghost cell or a hemolytic glaucoma, which is non-yielding for most of the standard medications, here also we indicate to go ahead with vitrectomy. And the last and the least of the indications would be an anti-alert proliferation despite adequate retinal ablation with laser or cryo, which might also help, the vitrectomy might help in these situations. So for our aid, as compared to the previous years, we have advanced technology which help us to safely tackle these cases, which include some to mention is high-speed cutting machines with pressure vents, smaller gauge cutters, which can help us to go beneath these membranes, valve cannulas, which prevents fluid fluctuations, bleeding, and dispersion of this heme in the vitreous cavity, and excellent wide-angle viewing systems. They're non-contact as compared to what we had contact systems previously, which helps us to keep the visibility till the end of the surgery. Chandelier sight system helps us to, free both our hands for the dissection in complex cases, and heavy fluids like PFO, which helps to settle back the retina. But in addition to these, the most common instruments which I preferably use in diabetic, which I always keep in handy, includes the forceps, which might be end grasping or a mass grasp forceps, and a curved scissors. Vertical scissors was to be used previously, but it's of not much in vogue in the recent years. Not to least to mention is the chandelier light system, which helps us to keep both our hands free for the complex dissection. So let me go dive into my cases directly. The the simplest of the diabetic widths is when the patient has a non-responsive diabetic macular edema. In this condition, you can see. So there is a thick hyaloid, which is adherent and keeping the retina taut and preventing the edema to resolve. So I've basically used tricot to stain the posterior cortex and to demonstrate how we go about. As in usual PVD, we go onto the disc and pull the entire vitreous up. But in these cases, we cannot do that. You can see that I'm trying to nudge and cut the connection between the disc and the fovea. Once that is achieved, go all around the fovea and then lift up the vitreous. This helps us to prevent the retina from getting, the inner layers of the retina from getting torn away, and helping us to clear the vitreous at the same time. My second case would be if a patient has, if we decide to do an ILM peeling along with the posterior cortex detachment, if the patient has a large cyst, it would be better to do a fovea sparing. This is what is being demonstrated in this video. So once we do a edge of the ILM and peel a defect all around, and then try to peel the centripetally peel the ILM towards the cyst. So this is basically essential to prevent the deroofing of the cyst and creating a lamellar or a complete thickness macular hole. Yeah, so once the ilum is peeled all around the fovea to leave the tangential traction, if it's long enough like this, we can go and trim the flap to prevent the attachment of floaters. The simplest of the other condition, the indications of vitrectomy, which was in the previous year, was the commonest being the vitreous hemorrhage. It's quite rare nowadays. Post the vitrectomy, the PRP, which was introduced in the DRS study. So here we have a simple case of subhyaloid hemorrhage, which is just about in the premacular region. So it is the tackling of such situation is very easy. We just, because there's not much of proliferation. So we go and just induce the PVD from the disc and lift up the entire posterior cortex. So once we get the edge of it, the entire subhyaloid bleed which is there comes into the cutter, and then inducing the PVD and completion of the vitrectomy is just a completion of the case. There's nothing much difficulty, but when inducing the PVD, you should make sure that the vascular nails have been taken care of appropriately. Otherwise, it might create inadvertent breaks during the vitrectomy process. So once this is completed, since this is an AY, there's no laser marks. We complete the surgery by doing endolaser photocoagulation as in the form of scatter photocoagulation itself. If there's a simple TRD, which is limited to the disc or into the papillomacular bundle, so in these cases, we can still manage to induce a PVD as in the regular cases. There's nothing much of an addition of the posterior cortex into the retina. The vascular nails are not present in these cases. So we can afford to induce the PVD as in regular cases and lift up the entire posterior cortex. So not so popular technique, which was introduced initially in diabetic wits, but it lost in its vogue. The reason I'll let you know once I complete this. So you can see a thick proliferation at the disc and emanating into the peripheral retina. So I've just gone over there, lifted up the posterior cortex, created a rent, and with a forceps directly go into that rent portion and lift up the entire posterior cortex in toto. So this was called as en bloc technique, where the entire posterior sheet of the vitreous is used to be peeled up, and then it's taken into the cutter in a single go. The usual issue with this is, since the vascular nails and other adhesions to the retina is not very visible, it might cause arthritic complications. One which you can see over here is a small break which has caused because of the pull on the posterior cortex. I was lucky enough to manage this because there was not that was the only adhesion which was there with minimal bleed around the surface of the retina. The rest of the bleeders were easily coagulated and laser was done. So because we cannot predict out the outcome of the traction on the retina and it might cause inadvertent bleeding and breaks, this went into this. So the present situation, we use two most important approaches, either the inside out or the outside in. So what I mean by inside out is, so we start the dissection in the posterior pole, that is in and around the macula or the disc, and then we go outside and then start peeling the entire membrane. In outside in, so we start from the outside as indicated by the black arrows, and then we dissect inwards towards the disc. So each has its own advantages and disadvantages. The advantages from inside out is that the membrane can be easily dissected. The second membranes which are to be looked for in the outside in is not to be worried about. The plane of dissection is easily identified and it can be easily taken up. But the problem is, if you create a break or if there's a bleeding, then it becomes an issue to continue with the surgery. As far as outside in, the basic disadvantages of the inside out can be prevented, but the peripheral detachment which can occur in an outside in becomes very messy. And if it becomes bullous, or if the second membranes are difficult to identify, then we might end up in the wrong plane and causing more breaks and doing more harm to the patient. So once the approach we have decided either outside in or inside out, there are two more important steps as far as the membrane dissection is concerned. One is segmentation, a large membrane rather than in toto, which we removed in en bloc. We cut open into pieces. So that is called as segmentation. Once the piece is created, then it is separated from the retina, which is called as delamination. So let me go walk you through some of the videos demonstrating this. So this is the basic setup where you have the standard 3 ports along with the chandelier inserted. The chandelier can be inserted either superiorly or inferiorly, or you can have a dual chandelier for a uniform illumination. Here, I'm trying to induce the posterior vitreous cortex separation from the disc. I'm going basically inducing the inside-out approach. So once that is effectively taken out from the disc, then I start going into the periphery. So with the separated posterior cortex, I go into the periphery and try to gently lift up the tabletop configuration of the fibrovascular proliferation. Once there is some amount of separation which can be made out of here, I'm trying to dissect out and cause a segmentation. You can see there is 2 proliferation on this superior temporal aspect where I'm just going between those fibrovascular proliferation and segment it into 2 parts. Once that is done, then we sit and delaminate each of the proliferation and complete the dissection process. Let me go from the second approach, that is going from outside to inside. This is a combined retinal detachment. You can see the break in the infratemporal to the disc. I'm trying to induce from inside out. It was not possible. So then I'm going from outside to in. Now I could induce the PVD trying to do a truncation of the cone, which is not possible in these cases because of the strong adherence of the fibrovascular proliferation. So once I get a plane, so superior temporally, I've already got a plane to dissect it. So trying the same technique of inducing the separation of the vitreous from the periphery. Sorry, just a minute. Yeah. So once that is done, from the periphery, we have dissected out the vitreous. Now, clinging on to the main fibrovascular proliferation, dissecting it out, first segmentation into the superior and inferior portion, and then delaminating it along the arcades. At each basic step, we need to make sure that we don't create any iatrogenic breaks, and the bleeders, as and when they start bleeding, if there is an arterial ooze, better to control it either by diathermy or by pressure ventilation, pressure vented, rather than leaving it alone, because if sufficient amount of clot forms, then that might itself cause another horrendous task of removing the clots, which is much more difficult as compared to the primary membranes. I've peeled the ILM to make sure that I have not missed on any second membranes or any other flimsy membranes on the macula. And once that is completed, an air fluid exchange and endolaser and tamponade is done. So it's not that we should always stick on to inside out or outside in. When you have a flat proliferation like this, where a single technique may not work, so identifying the plane in the periphery, it might be very difficult in a flat proliferation. So we start from the center, try to dissect it out into the periphery. So like what I'm doing right now. See, once I've got the edge, so I've induced the PVD into the periphery aspect, and then trying to truncate the cone all around the fibrovascular proliferation. So once the entire fibrovascular proliferation is segregated from the periphery, then I start attacking the membrane per se. So here I've started in the center, went to the periphery, finished up the truncation of the cone, and then came back inside to complete the dissection process. So this is a combined approach, and it's more essential when you're trying to approach a flat proliferation where you don't get a specific plane for dissection. So despite doing the best of our efforts, it's very disheartening that some patients do come back with recurrence with breaks. So in this patient, you can see that a large break has happened because of the contraction of the membranes, which has formed just at the edge of the end of the arcades. So carefully identifying the membranes, dissecting it out gently without much of traction, because if we pull it very hard, then the break might extend and cause further breaks because of the ischemic retina and the laser retina, which might give away very easily. So we need to gently peel that membrane along with the aid of PFCL, which I've used here. So there are three different areas where the breaks have formed. The superior temporal was the largest one, the inferior temporal, and the temporal aspect. So three different proliferation at three different sites. So once the dissection of this proliferation is complete, we always have to go into the periphery to look at if there is any anti-alert proliferation or any other vitreous which is adherent or remnant vitreous which is there, because that might cause a recurrence once we think that we have taken care of the posterior pole. So once there is a recurrence, always we need to go to the periphery, remove all the vitreous which is remnant, then go ahead with a air fluid exchange and endolaser and tamponade. So, sir, Sumit sir, do we have time, or should I stop here because it's already 18 minutes?
Is this your last case that you?
Yes, sir. This is the last case.
Okay,
That is
no problem. Go ahead.
So, putting all this into conjunction, let us see what we can achieve in a patient, a type 1 diabetic. So she was recently diagnosed when she complained of visual issues. She was not a known diabetic. Visual acuity in the right eye was 624, left eye was 5/60. Diagnosis was bilateral TRD involving both the eyes, left worse than the right. This was the fundus to begin with, the left and the right, with dense neovascularization. So I'll just run through this video because it's pretty long. So this is again the setup. As you can note that there are two chandeliers and a thick proliferation adherent to the entire retina. So start the dissection inferiorly with the 24 gauge needle. Since I've I've truncated the vitreous, peripheral vitreous from the central prolif. So once that is done, it is easy to lift up the entire fibrous proliferation in a membranous format and try to dissect it out. So cauterizing the bleeders and dissecting the membranes, then switching on to bimanual and carefully cutting out all the vascular nails to separate the fibrovascular proliferation from the underlying retina. So in this process, we end up having a lot of bleeding and a number of clots which might get strongly adherent to the retina. So we have to pursue the dissection process. We cannot just leave it in the midway and try to cauterize as much as possible. Liberal use of cautery is very essential in this cases. And as and when possible, the membrane has to be shortened so that we have better visibility of the underlying retina. So clot dissection is, I'm trying to see how much I can peel off the clots from the residual, the retina, to try to flatten it out. So I'm just running through it because lack of time. So post-op 2 weeks, we can see that I have tried to achieve where I started up with a fairly attached retina and a good visual background. After silicone oil removal, the vision is stable at 6/9. So lessons learned is every diabetic vitrectomy is different. I need to assess the condition and approach appropriately. Appropriate use of technological supports, which includes smaller gauge cutters, whichever is the surgeon is comfortable with. Bimanual approach, it's a lifesaver in a variety of vitrectomy cases, especially diabetic. So keep it ready and in handy whenever you want to just switch it. So always switch it. Don't have an hesitation for it. So I spoke about two techniques. Some say inside out is better, some say outside in is better, but no technique is better than the other. It all depends upon the surgeon, whichever is which is convenient to him. So he should engage that or use both of them. I had showed in one of the flat proliferation cases. The common factor for all the success in all these cases is the surgeon skill. That should never be supplemented with any of the other machines or instruments. I thank you for this time and patience hearing for my presentation. Thank you, sir.
Oh, thank you so much, Rajesh. It was indeed a treat to the eyes, and I'm sure a lot of people will, call you up for their taking tips on doing a diabetic vitrectomy. Next, I would like to invite Dr. Rohan, sir, who will be teaching us on central serous choroidal retinopathy. And may I request Dr. Manisha Nada, ma'am, to introduce sir?
Good evening, all. I introduce Dr. Rohan Chawla. He is working as associate professor in AIMS and has done FRCS, and also he has done 3 years fellowship from All India Institute and is a phenomenal speaker. And I would request him to now come with his thoughts on CSCR. Dr. Rohan, over to you.
Thank you, ma'am. Thank you very much. And thank you, Dr. Khanduja, for inviting me to this webinar.
Yeah, Rajesh, I think you'll have to switch off your screen share.
Very nice videos, Rajesh. It was a treat watching your surgery. Definitely.
Thanks a lot, sir. Thank you.
Okay. I will go on to share my screen. Can you see the screen now?
Yes, sir. So you're audible and your screen is visible.
Okay. So I'll be talking on central serous chorioretinopathy. So from CSR, it is now CSCR, because now choroid is thought to play a major role in the pathology. So just to give you an idea of a typical patient, is a young male, might have anxious personality with some mild to moderate blurring and complaining of a central black patch in the field of vision or metamorphopsia. So if a patient walks with just these 4 things into my OPD, a young patient, I think the first thing that should come to your mind is this diagnosis. And in many cases, just seeing the neurosensory detachment, the diagnosis is fairly easy to make. But these are typical cases. And these are typical angiographic features where you find the ink blot leak or a smokestack type of leak. ICG has recently showed us increased fluorescence of the choroidal vasculature, and OCT definitely confirming the diagnosis. But as I said, this is a typical patient. Now I'll be showing you situations where it is looks like CSR, but it may be something else, and also some atypical types of CSR. So just to go into the pathophysiology, the recent thought process probably is that there is an increased flow through the medium and large choroidal vessels and overlying thinning of the choriocapillaries, which is also referred to as probably a pachychoroid type of situation. And finally there is a micro rip in the RPE, which leads to this fluid seeping it into the subretinal space. There is no rip, there might just be an isolated PED. This is one of the proposed hypotheses, but most commonly observed. So this is a standard case where I marked the arrows. You see that there is a fluid like bulla here, where the retina is losing its transparency. You do an OCT, you get the subretinal fluid, and your diagnosis is confirmed. You do an angiography and you get your typical leak. But now let us see this case. So here again, where I have marked with the arrows, you feel as if there is just fluid there. And this case was in fact referred to us as CSR, because someone had done this OCT and they found that there is subretinal fluid. But it is important to look at all the sections of the OCT. Then someone else looked at this section and then came up with a diagnosis of optic nerve head pit, which is leaking fluid under the retina and into the retina. So it may be an optic nerve head pit maculopathy. But when you look at it more carefully, and we also performed an OCT angiography, you look, there is a yellowish lesion here, and look, the OCT angiography is showing that that area is forming a choroidal neovascular membrane. This is actually a case of idiopathic choroidal neovascular membrane. We gave him anti-VEGF and this OCT, and it's just after about 3-4 days of the injection, it's already started showing resolution of the fluid. So one has to be a little careful. One should look at additional findings apart from the fluid when analyzing cases of CSR. Now this is a case which shows a pigment epithelial detachment. Again, a youngish patient. So one might want to make a diagnosis of say type 2 CSR, where only PEDs exist. But what you need to see here is, I hope you can see the arrow pointer where I'm marking. Yeah, so this area here, there's something like a double membrane. Yeah, okay. So double membrane sort of formation where there is some hyperreflectivity under the lifted RPE. So this is not to be ignored. So you can also see stippled hyperfluorescence on fluorescein angiography and probably a membrane-like structure on ICG, which we did consider it to be a CNVM, and since it was extrafoveal, we treated it with just reduced fluence PDT, and we definitely got a response. So again, you can have these subtle sort of membranes in these cases of pachychoroid spectrum. So this pachychoroid spectrum is basically those thick choroid which can range from just minimal pigment epithelial changes to a CSR, to polyps, and also secondary choroidal neovascular membranes. So one has to be a little careful with these patients with the thicker choroid. So another patient where you see fluid, but along with it, there is a lot of exudation also. Although there is a tract going inferiorly, which might suggest a chronic CSC. But again, if you do a angiogram, you will see that there are not just simple CSR-like features, and OCT also shows you larger PEDs with this subretinal hyperreflective material. So again, this is probably not just CSR, and so much exudation would not come out in cases of CSR. So again, probably a case of polypoidal choroidal vasculopathy. Another example of a CSC going into PCV. So right eye, you can see the bleed. So definitely something has bled there, choroidal neovascular membrane. You see the ICG and FA, you can see some of these polyps in the right eye. In the left eye, you see just a subtle patch of granular hyper reflectivity. ICG shows increased choroidal vessels here, and some may be focal leaks. So probably this left eye is still in the CSC stage, may progress into a polypoidal choroidal vasculopathy like the right eye. Right eye has the thumb-like PED with a double layer sign, whereas left eye still just has mainly subretinal fluid with a little bit of pigment epithelial hump there. So we have to be careful about these cases where a CSC goes into a PCV. Now look at this case. This case again, you might see that there is fluid at the posterior pole, especially in the left eye. And the additional things to be noted here is look at the disc. You see the disc in the left eye, definitely the margins are not as well defined as the right eye. There seems to be a little hyperemia also there. You do an OCT, you do find your subretinal fluid, but again, you don't jump to CSC. Look at the RPE. It is also a little lumpy, bumpy. So this can happen in cases of inflammation. This can happen in cases of metastasis. So in this case, to further confirm when you do a fluorescein or an ICG, ICG typically shows you those hypo patches. So where the inflammatory cells are there in the choroid now, you are not getting dye over there, and you're not getting the increased choroidal fluorescence as you were getting in the CSC cases. So this is basically a case of Vogt-Koyanagi-Harada syndrome. Again, you see fluorescein angiography showing you a hot disc. There is even the other eye is showing a little hyperfluorescence on the disc. So VKH and CSC can be easily confused, and they must be differentiated. VKH patients generally could show cells also in the anterior chamber and in this associated anterior uveitis, but they need to be differentiated because the treatment is exactly opposite. VKH, you have to give steroids, whereas CSC, you have to avoid the steroids. So although many times we are able to make a clinical diagnosis, but if you have a doubt, go ahead, do an ICG. That will definitely resolve your confusion. In other case, young patient with what looks like fluid at the posterior pole in both the eyes, but again, don't miss these yellow patches here. So if you do an OCT, actually, although you seem to have these fluid filled cavities, but again, this hump at the subretinal level or the level of the RP. So these cases with a symmetrical pattern, they are more likely to be actually vitelliform dystrophies. Now here actually I don't have a fluorescein autofluorescence of this patient, but fluorescein autofluorescence clinches the diagnosis because these yellowish patches definitely start showing increased autofluorescence. And if you still want to confirm, your best disease would definitely have a EOG abnormality. So vitelliform dystrophy, consider you have young patient with bilaterally symmetrical picture. So another case where in the left eye you see fluid at the posterior pole, but don't forget to look at the disc. So these cases where you have some, actually this flash has come a little more bright here, but here these are cases of optic disc pit maculopathies where apart from just the fluid, in the subretinal space, fluid is also causing intraretinal chysis and extending on to the disc. So these optic disc cavity abnormalities, apart from disc, you can have other cavity abnormalities also, which might at first glance appear as CSC, but if you look at the disc carefully, you'll be able to diagnose these. Now look at this another case where you appear to have again this discoloration here, where the choroidal reflex is lost, so there's fluid accumulating here. And if I show you the OCT again, you will see that there is subretinal fluid, but so many hyperreflective dots here in the subretinal fluid as well as in the choroid. So is it again a case of VKH like I showed you earlier? Well, actually here we had a pre-diagnosed patient. This was a known case of leukemia. And so this is a case of leukemic retinopathy where the leukemic cells are infiltrating into the choroid and causing this exudative detachment. Now, VKH actually has also been described in CML, but this case was actually of ALL and these detachments resolved only on chemotherapy. So I'm a little hesitant to call it VKH. It is probably a direct leukemic infiltration. Another case where you see large amount of fluid at the posterior pole. If you look carefully again at the above the disc, there is a lesion there. So this fluid is coming from that leaking lesion. If you do an ultrasound, you'll realize that it is nothing but a small hemangioma, which has a very uniform reflectivity on ultrasound. So small choroidal tumors also can lead to fluid at the posterior pole. So again, not a case of CSC. Now we did photodynamic therapy for that and see this fluid at the posterior pole has now totally resolved. Little bit is remaining and the scan which is going through the tumor still shows some changes, but probably we can just follow up this patient for present. Now, this is a recently described entity called dome-shaped macula in high myopes. Here, instead of a posterior staphyloma, the sclera is somehow bending inwards. So because of that pressure, perhaps again the pressure in the choroid increases and some fluid exudes under the retina. This is not CSC, no laser, nothing required for it. Presently, mostly people recommend a follow-up. Another example of dome-shaped macula without fluid. So you can have them with fluid or without fluid. In other case, first OCT would probably tell you if it's a young patient, you would consider CSC. But again, don't ignore these other RP abnormalities which you are seeing on the OCT. If you do a FAF, it's showing some patterns sort of dystrophy, but it is this patient was not actually a pattern dystrophy also. If you see FFA, you are not getting your typical ink blot leaks. You're not getting the typical increased hyperfluorescence on ICG. So this patient is actually a case of SLE. And so this patient has an SLE associated choroidopathy. So you see many diseases which are causing choroidopathy are going to cause exudation of fluid at the posterior pole. So these need to be differentiated. So this was a case of SLE choroidopathy. Again, in this case, I would give steroids and increase the immunosuppression rather than avoid the steroids. So this patient again was referred to us as CSR, but here you see the something which looks like a fluid filled cavity. It is inverted, it is upwards. And actually what this case is probably a case of Valsalva retinopathy, where the sub-ILM bleed has mostly resolved. And you can see the ILM is being separated, no subretinal fluid at all. And here some brownish material is there, some residual blood. So sub-ILM cavity, which is mimicking a fluid-filled CSR. So you have to know the points which go against a diagnosis of a typical CSC. Look at the disc, look at additional deposits, take a systemic history because systemic diseases can also cause it. Fluid at the posterior pole, like I showed you. Simple hypertension can even cause fluid at the posterior pole or even exudative detachments bilateral. So, and additional findings on the OCT are important. Additional dots, additional undulations, and sometimes OCTA can be helpful in picking up CNVM membranes. So these are some things you should have to keep in mind when it's not a typical case. Now I will go to some atypical CSC manifestations. So here you see some yellowish deposit here, yellowish white. So sometimes these cases are confused with choroiditis, but there are no cells in this case. The disc is normal. You see the OCT, the RP line is very flat. Only yes, the fibrin deposit is seen. This is actually just a simple case of CSC with fibrin deposition. And you see the FA also, the leak is somewhat like an ink blot getting larger with the phases. So this is CSC with fibrin. In other case, again you see this deposits yellowish creamy under the retina and some subretinal scarring. These are absolutely normal, media clear, no cells. You do an angiography, again you see those multiple ink blot type leaks. And although the OCT is quite dramatic, showing you intraretinal fluid, subretinal, as well as the fibrin, which is showing hyperreflectivity. But again, just a case of multifocal CSC. So wherever it was possible, we lasered these extra foveal leaks. And although he did develop a lot of subretinal scarring and RP rip in the left eye, but still the posterior pole is now much better and the patient did definitely gain vision. In these cases also you must take history of steroids, because sometimes patients who are taking steroids tend to develop such large multifocal CSCs. So like I said, even exudative detachment, the fluid is too much in amount, the whole entire retina, inferior retina might appear detached. So it can cause fibrin and exudative detachment also. Chronic CSC, sometimes you might have these pigmentary tracts, which are the telltale signs that this patient has been suffering from CSC for a very long time, and nothing else to be done for it. It's not ARMD, it's just chronic CSC management. I'm just going to come to. So how do you manage once you have made a diagnosis of CSC? So if it is acute CSC, mostly we advise observation, but till when is a bit of a question mark. Most people would not like to suffer from visual disability for months. So probably a month is what we are looking at, not more than that. So we can seriously keep looking at the OCT. We don't need to perform angiographies at all sittings. I probably only perform an angiography when I have planned that now I'm going to take up this patient for some kind of laser. So if there is an improvement, you can still continue to observe, but you can otherwise intervene somewhere around 4 to 6 weeks. So chronic CSC, some people say chronic is 3 months, some say 6 months, but on an average, for fluid is persisting for more than 4 months, it is said to be chronic. We would not like patients to develop chronic CSC, because these patients then tend to, the fluid tends to persist and intraretinal changes start occurring, and then probably we will not be able to salvage vision to a very great extent. But what can we do? So during observation, if the patient is on steroids, any form, even inhalational steroids, topical, cream, stop them, control the blood pressure, ensure that patient is having adequate sleep. Sleep apnea has been known to have a risk factor for this, and give them anxiolytics if required. So this is one of the things, and it does help in quite a few patients. As such, also acute CSC does not have a very bad natural history in more than 60% patients. But if nothing is helping, fluid is persisting, then I think of all the therapies and of all the trials, to, at present, I would say photodynamic therapy is probably the treatment of choice, because it will not lead any scotoma and it has shown most consistent results. But to avoid the side effects of photodynamic therapy, half fluence, and even combined, we have done half fluence, half dose. Even that little bit of therapy works. And but only thing is, yes, even after photodynamic therapy, you can have recurrences, new leaks can develop. But we can even do this for subfoveal lesions. But I've had one patient who has developed a scotoma because of a choroidal ischemia after photodynamic therapy. So since then, I never do full fluence. I always do half fluence and even reduce the dose of vertiporphyrin while I'm doing photodynamic therapy for CSC. Now we recently got this subthreshold laser. I've tried this also. So here we just give a laser burn which is just visible, and then we reduce the duty cycle to 10%. So so much less energy is now going in, and for a very fraction of a time. And but only I've seen that one hit doesn't help. We have to give 4-5 hits, but with this reduced energy. And we have a yellow laser which is said to be more fovea friendly, but it can even be done with a double frequency YAG. And in my hands, I think the effectivity is somewhere around 50%. It's not like PDT, but yes, cost is much less, and I am doing it for patients who can't afford PDT and we don't have any other option. So it is said not that it doesn't damage RP as much as a focal laser. So this is one patient of where we have done subthreshold laser. Leak is quite close to the fovea, and post laser there is definitely marked reduction in fluid. So for extrafoveal leaks, definitely leaks which are away from foveal avascular zone, you can do PDT, or if you don't have PDT or it's too expensive, you can definitely go ahead and directly do a focal laser. It definitely has a good effect. And like I showed you in that patient of multifocal CSC, we manage with focal laser. Medical therapy has also been talked about. Eplerenone is a mineralocorticoid antagonist having lesser side effects. Generally start with about 25 to 50 milligram. In some cases, we can go even higher if the patient has a higher body weight. But do keep a check on potassium level, and ask the patient that if he reports symptoms of weakness, then probably you need to stop this therapy. So again, whether it is effective or not, it's controversial. There was a recent study in Lancet which definitely said stop using eplerenone. It is as good as a placebo, but I would still say it has effect, and I still use it in chronic CSC. And I've seen cases resolve on it, and you stop it, and they come back with fluid. You start it again, they again resolve. So you might have to give it for a long term. You might have to give it 6 months and continue maybe even longer than that. Whether you should give it in acute CSC is controversial, but some patients who really want therapy are also keen on having it resolved. I have tried it in acute cases also, but I again cannot comment whether eplerenone helped or it was just the natural history of the disease which helped. We will also have tried ATT, Diamox, Dorzox, NSAIDs, but I would say no definite role. If you at all want to give something other than eplerenone, avoid rifampicin in our country because of the tuberculosis issue, resistance issue. You can rather use ketoconazole or mifepristone. I have personally used ketoconazole, not mifepristone. Thank you. Thank you very much. I think we'll take the questions later.
Yes, sir. Thank you so much for the presentation, sir. And sir, the questions, sir, we'll be taking at the end of the session. Sir, now I invite Dr. Raju Sampangi, sir, for his talk. And may I request Dr. Jitendra Fogart, sir, to introduce Dr. Raju?
Hello, everybody. Dr. Raju Sampangi has completed his MS from AIMS and also his vitreoretinal residency training from RP Center AIMS. He is an innovator at heart and developed a new universal attachment for payment lens for retinal wide-angle viewing system. Also, he has recently developed a new adapter for 3D recording. He is a renowned vitreoretinal surgeon and now practicing in Bangalore. Thank you, sir.
Yeah, thank you very much for that kind introduction. At the outset, I would like to thank the Ophthalmic Society of Karnal Eye Surgeons at Karnal and Dr. Kanduja in particular for giving me an opportunity. It was a treat to listen to all the talks before. Dr. Rohan, my teacher, and Dr. Rajesh gave very excellent talks apart from Dr. Rajiv Raman and Aditya. All the retina specific talks. My talk is going to be on something that will be very useful for all the general ophthalmologists who are the first contact for all trauma cases. And all this collection of cases that I'm going to show you are real and they have happened to us. And these are the mistakes that we have noted down. And it's better that we all understand what mistakes can happen and how we can prevent them in future, especially in trauma, because these cases are most likely end up as medical legal cases. So when can mistakes happen in trauma cases? Actually, it can happen at the time of history taking, at the time of examination, the management of these cases, the follow-up, and more importantly, the documentation of these cases. So let me try and explain to you with some case scenarios. This is the first patient, a young girl, a 4.5-year-old girl, came with injury to the eye, and she was found to have a small red spot, and she was brought to the hospital within 1 hour of trauma to the OPD for checkup. And on examination, there was a very small subconjunctival hemorrhage and probably a small self-sealed penetrating injury about 4 millimeters from the limbus. The child had a vision of 6/6. The patient was treated with topical medication. The patient parents were very anxious. They were reassured that it's a small wound, it will heal and nothing to worry. The child was actually called for follow-up after 1 week. Now, do you feel there are any gaps in the management of this case? Do you expect yourself to be dragged to the court in this case in future? Do you take this case lightly or seriously? And what do you tell regarding the vision? What do you prognosticate to the patients regarding the vision in future? Actually, this child unfortunately developed endophthalmitis on the 3rd day. And the history, when they took a detailed history, it turned out that they're playing bow and arrow, and the arrow was with a broomstick while playing. So the whole situation now changed just because the injury was with a broomstick. So what you learn from this case is a thorough history is important. always try to get a mental picture of the injury, recreate the scene of the injury, and corroborate it with the findings of examination. If there is a mismatch between the history given and the findings, a warning bell should ring in your minds that this case is a potentially medico-legal case at a later point of time. Your findings should corroborate with the history. If it is not, then there's something amiss. Especially if a broomstick is injured, always keep in mind that a very close watch is required in these cases, as this can end up with infection. And if you need to intervene very early, as for that, you need to call these patients quite often. This patient number 2, a 60-year-old man who came with injury following a fall from the bike. The patient presented immediately after the injury. The vision was 6/6. Patient had a mild concussion injury on the forehead, as you can see here. What next would you do? The patient was given topical medication and was asked to come after 2 weeks by SOS. After 4 days of using the drops, the patient came back with this kind of a picture. Now, what do you do now? Still, the vision is 6/6. Anterior segment and posterior segment are normal in this case. So would you continue the same treatment? Would you give anti-inflammatory medications? Would you investigate further? Actually, this is raccoon eyes. This is a sign of underlying trauma, and most of the times it can be an indicator of basal skull fracture or fracture of the facial bones. So this requires an urgent CT scan and a neurosurgery consultation. The case number 3 is a patient who presented to me 12 months after an injury, and he was coming for a second opinion. The patient was traveling on a bike and was hit by a vehicle that was coming from the wrong side, and he fell down. The patient was not wearing a helmet at that time and fell on the pavement and hit on the left side forehead. There was no loss of consciousness. He had bruises and a fracture of his tibia. He was treated in a government hospital where his fracture of tibia was treated. And at that time, an ophthalmic consultation was also sought. The patient was noted to have periorbital edema and subconjunctival hemorrhage, and bedside vision was noted as equal in both the eyes, and patient did not complain of visual problems at that point of time. Fundus was reported as normal. Patient was asked to review in OPD after 3 weeks. However, 12 months later, the situation was something different. The patient had filed a case against the person who was involved in the accident. The patient sent for second opinion as per the request of the opposite lawyer. The vision in the left eye was actually PL positive, and the lawyer was alleging that the vision loss was due to medical mismanagement. The patient had a traumatic optic neuropathy. Now, what you learn from these 2 cases is any injury in the region of the brow or a forehead can cause fractures, and the fractures can involve the optic canal. And it's always important that we order a CT scan and very specifically write for cuts of the optic canal to rule out any bony fragments in the optic canal. Because if it is found, at least we can treat these patients by a surgery, decompression surgery can be done in these patients. So it's very important in these patients, whenever they have a trauma in the region of the brow, that the risk of traumatic optic neuropathy should be explained to these patients. Case number 4, this was seen in a hospital where I'm a visiting consultant for Retinal. A 26-year-old male patient presented with something hitting the eye and falling off while he was standing in a workshop. He presented within 2 hours. Patient was seen at 6:30 p.m. in the OPD. It was the closing time. At that time, again, the vision was 6/6. Patient had a subconjunctival hemorrhage nasally. The antechamber was clear. The patient was actually given topical antibiotics and cycloplegics and was asked to come the next day for a fundus examination. Now, what this patient did was, because his vision was normal and he was comfortable, he did not come back for the eye examination. 1 month later, however, he came back with a finding with a complaint that his vision had dropped in his injured eye. And when we saw him, he had an inferior retinal detachment and a suspected intraocular foreign body. When the information about the RD was given and a possible intraocular foreign body was given to the patient started accusing that no follow-up was advised. Luckily, however, we had clearly documented in his file that a dilated fundus examination has to be done the next day. And this documentation helped us to make the patient realize that it was his mistake of not following up. So it is very important in these cases that you should make sure you write it in bold and stress the same to the patient that he requires a fundus examination, and also get the patient to sign it. This is what the corrective action that we took after this patient accused us of not telling us or stressing the need for follow-up. So always try to get a signature of the patient or the attender along with their names and the phone numbers. This patient number 5 who presented with a history of trauma about 6 months back, the patient had a self-sealed corneal wound and cataract. The patient was advised cataract surgery, but he came to us for getting operated. Now, what do? You jump in and proceed and operate on this patient for cataract surgery? Obviously, no. We'll do a B scan. We did a B scan. It was anechoic and no foreign body was seen. Now, let us see what happened during the surgery. The steps of the surgery were routine. We did the CCC and started with the phaco. When we were doing the phaco, there you could see the foreign body. It was an intralenticular foreign body. The foreign body had lodged inside the lens, and we removed it, and the IOL was implanted. Now, actually, in this case, I had seen this patient pre-op, and I had done the basic. The exact location of the foreign body, and in this case, so we took an informed consent that there is a ventricular foreign body, and in case it drops down to the posterior segment, we may have to do a retinal surgery. This was told to the patient. So this kind of preparation helps us in handling these cases better. Now, coming to case number 6, a patient coming to us 4 months later, and he was coming for a second opinion. And whenever a patient comes for a second opinion, make sure that you document each and everything correctly. And this was a 16-year-old boy who came with history of injury at workplace and something hitting the eye while hammering. He had shown to a nearby ophthalmologist. The patient had a penetrating injury to the cornea with foreign body stuck in the wound. There was also injury to the iris and the lens. The foreign body which was there stuck was removed and primary wound repair was done. The patient was explained that cataract removal will be done at a later point of time. However, it was postponed repeatedly because there was an opinion 4 months after the incident. Now, when he came to me for my consultation, he was accompanied by father and also by the company manager. It's also important when somebody comes to you, especially with a history of trauma, a factory where it happened in a factory, always look at who are all accompanying the patient, because you will get a hint about the medical legal aspects of this case. Now, I was going about asking about the history of the trauma, the nature of the trauma, were there any surgical records? And I also casually asked him, was there any X-ray or a CT scan done? And the reply was given by the manager. He gave me all the OPD details of the consultation. And he also started in an accusing way or a combative way that other doctor never asked for an X-ray or a CT scan. So when we saw him, this picture was something like this. He had a repaired corneal wound, and you can see a partially absorbed cataract. This is how bad the eye was. What next? Would you do a B scan? We did a B scan. It was normal. Now, would you go ahead and operate this case? I got a CT scan done in this patient, and there it goes. The patient had one more foreign body. It had broken down, and the other foreign body was in the intraocular foreign body. Now, this patient was actually managed by an ophthalmologist whom I knew. Discount, had explained to the patient about the guarded prognosis. However, CT scan and X-ray was not done keeping in mind the economic status. The parents were, however, instigated by somebody to file a case against the company because he was a 16-year-old kid. and somebody instigated him to file a case for workplace injury. The company management had to pay for the compensation now. Now the blame game of mismanagement by the doctor started. Now we explained the very guarded prognosis, and we also asked for an ERG just to document the case further. Now what happened in this case was, after the CT scan came positive for a foreign body, a group of people from both the patient side and the company side landed up at the first doctor and created trouble and said that he had mismanaged the case. The doctor had to buy peace by giving money for further management, which was 10 times more than what he had initially taken for treating this patient. All this happened because of lack of proper documentation, no proper consent was taken, and there was incomplete investigation. So it's very important in a setting of trauma, a new suspected foreign body, make sure you document it properly, have a very clear communication, have a very low threshold for ordering a CT scan, and always order a CT scan with 1 mm cuts to rule out an intraocular foreign body. If the patient is not willing to get a CT scan done, you can document it, write it down in the file. The patient doesn't want to get a CT scan and get a signature done. At least your job is done. Next, coming to the last few cases, is a patient who came with a history of injury with a tennis ball 1 week after the injury, and this patient was diagnosed as Berlin's edema. Second opinion was taken as vision did not improve 1 week after treatment, and with oral steroids and topical steroids combination was given, and the vision had not improved in this patient. The vision was at the time of injury, when it was seen first day, it was counting finger close to face, and at 1 week also it was same. Now when we got the OCT done, this is how the OCT looked like, and this patient had a subretinal bleed, a subphotoreceptor bleed. Now most of these patients who have a subphotoreceptor bleed or a subretinal bleed are sometimes misdiagnosed as Berlin's edema and treated conservatively. So this is a take-home message. So whenever you suspect that there could be a Berlin's edema, always get an OCT done just to rule out a subretinal hemorrhage. And in this case, the patient was treated with SF6 injection, and you could see here the hemorrhage getting displaced and the patient vision improved. This is another patient who came to me at the same time. He also had a history of injury with a tennis ball, and this is how his retina looked like. He also had a subretinal elevation, and this elevation was actually sub-RP. It was below the RP, and this was also a subretinal hemorrhage. In this case, we didn't treat and actively with a gas or any other intervention. We just observed this patient, and over a serial follow-up, this patient improved from counting finger 1 meter to 6/9. So that's because this hemorrhage was sub-RP. And this was the first publication in literature, world literature, that we used a SDOC to differentiate the traumatic submacular hemorrhage using automatic 3D segmentation analysis. And the take-home message in these two cases is, if it is sub-photoreceptors, then we need to do a pneumatic displacement. If it is sub-RPE, then we can just observe these patients. So in a setting of blunt trauma, always think beyond Berlin's edema and keep in mind a submacular hemorrhage. So other things that we also need to do is to do a good peripheral IDO to rule out a retinal breaks and dialysis, a gonioscopy to rule out angle recession glaucoma, especially if it is a blunt trauma. And we should also document in these patients that regular IOP measurements and IDO examinations are required. This has to be documented in these patients. So take-home message is documentation is important. A good history taking is paramount. Understand the circumstances of the trauma and always try to correlate your findings. Patients may give false history initially, especially in assault cases, and then later come back when instigated by others to file cases. And then they'll want to certify the injury as severe. Knowing a good history will also help us guide our examination, investigation, and where we prognosticate these cases. When in doubt, always investigate. Not only to prove something positive, but also to rule out something sinister. Potentially, every case can be a medical legal in a setting of trauma. This has to be kept in mind. So every ophthalmologist has to be familiar with the loss in effect. A thorough documentation is very important to save ourselves in future. Investigate, be updated with the latest in management, and refer appropriately if required. These are the take-home messages that I would like to give. I would like to thank again all of you for giving me this opportunity of sharing my experience in ocular trauma management. Thank you very much.
Thank you so much, sir. Thank you for your intellectual presentation, sir, and your teaching. I think we can all switch on our mics, and there are some questions from the audience that I would like, especially Dr. Sudhalkar and Dr. Rajiv Raman to answer. Yes, sir. May we have the mics on, please? Dr. Rajiv?
Yes, sir. Yes, sir.
Yeah, hello, sir.
Yes.
Yeah.
So the first question, it comes from Dr. Praveen Garg. He says, after how many days of injection of Brolucizumab does the patient start improving vision, or it depends upon the severity disease or from individual to individual? What has been your experience, sir?
So first, let me just give a disclaimer that I have not injected any patient till now with Brolucizumab, because we have our protocol, and unfortunately, none of the patient has fitted into our inclusion criteria. So at Shankar Nethralaya, we have not given any injection. However, the literature and even the experience of our colleagues, it seems that it is a good drug, and you start immediately. People have shown even within a week, repeating, and couple of days, 4 days, 5 days, the improvement starts. So it seems to be a very good drug as far as it. People have used even in other diseases, and I've seen very good response in DME or vein occlusion. So it definitely works pretty well and pretty quicker.
Okay. Sir, just a quick sir comment from Dr. Aditya and Dr. Rohan, sir, please.
Yes, sir. I mean, I wrote it in the chat box that for switch patients, it is quite variable. So, but even this patient, who had the Indian patient, he had received 25 injections, but then within a week, he was able to appreciate the difference. Whereas for treatment naive patients, I think they come back within the first 3 or 4 days, because in Germany, one of the protocol parameters is that you follow up patients on day 1, day 7, and day 30. So most treatment naive patients have reported improvement on day 7 itself when they come for a dilated exam. They said that by the 3rd or 4th day, we could appreciate improvement in vision.
Okay. And Dr. Rohan, sir, your comments, sir, if you have used?
Dr. Rajiv mentioned, personally, we have not used it at RP Center as of now.
Okay.
And we are just watching others. Let us see how good or bad the drug is. If significant side effects are being reported, then probably we will not be using it. But definitely, to my mind, where I would like to use it is those patients whom every 6 weeks the fluid just comes back. So those recalcitrant patients for whom we don't have any option, whether you use aflibercept, whether you use Lucentis, add PDT, whatever you do, maybe those are the cases where you would like to use it initially. But as of now, I have no experience, no personal experience.
Sir, Dr. Rajiv, sir, one request, sir, just like you have an evaluation sheet in Shankar Nethralaya, if you could share it with us, and so that we could implement it in our practice, and
Absolutely
it could be a
true.
source.
I can send you our evaluation sheet. We have a couple of inclusion and exclusion criteria which we have decided. So I think that would be the nice way to start, because you want to be safe.
Yes, sir. Yes. Sir, and one thing I wanted to ask was that if it is such a good molecule, why can't it be used as a primary therapy in our cases? Why to reserve it for recalcitrant neon-dependent
No,
cases?
no, no. Actually, even the side effects, what has been described is that those who are, again, it's not the experience of people. So I was in one of the webinar where Dr. Mark Smith, who is part of the SAE committee, he suggested that these cases who have treatment naive, they have less chances of inflammation as compared to those who are on prior injection. But again, see, it's just the safety. You don't want a treatment naive eye to, it's just the safety issue. That's the reason you are looking for eyes who are already treated with couple of drugs. You are justified that nothing is working now. Probably let's try this.
Okay, sir. Okay. Sir, just a request, we would like to have the evaluation sheet, and if any, Dr. Salil has requested for a consent form if you're
Yes,
taking.
I'll send you the consent form also. We have a little different consent form for it.
Okay.
I can
I think
send.
this was also a query from Dr. Parul. She said that if there was any experience from RP Center. So I think Dr. Parul, we till now RP Center hasn't used it, and at SN they haven't used any of these cases. And I think Dr. Sunil Agarwal said that Apsipar and Brolucizumab seem to be promising, and both have shown little disappointing safety profile. And he's mentioned about some drug Faricimab. So,
Yes.
sir, any comments upon that?
No, absolutely right, Dr. Sunil Agrawal. We have a lot of exciting things coming. Actually, definitely these two molecules, efficacy-wise, both are, even Abacipar had shown very good efficacy, but inflammation was a problem. There are many new drugs, but we really don't know how the either inflammation or some new effect we will see. But definitely the future times are very encouraging, because even the the implants where you can reservoirs, or even there are thought of using gene therapy, that's also in phase 2 trial, where it's like a factory. So a factory of aflibercept. So you introduce a gene which itself produces aflibercept or ranibizumab inside, so you don't have to inject. So there are a lot of new concepts which are coming up, and I'm sure next few years we'll see a better drug.
And so there is one question for Dr. Rajesh from Dr. Ruchi Mittal. She has asked that in what cases do you prefer to give an anti-VEGF prior to surgery? Rajesh?
Thank you for that thing. So usually I don't, nowadays I have stopped giving, but if the vasculature seems very angry, and if too much of, blood vessels are there where you expect a lot of bleeding, or if you have operated one eye and the fellow eye needs a surgery, in the operated eye, if you have encountered a lot of bleeding and clot management was difficult, then you can definitely try giving in the fellow eye and then taking up for surgery. But I haven't seen much of difference between preoperative bevacizumab and doing surgery without it in such cases. But it's each individual choice. But most of the surgeons do agree that the operating time as well as the clot management is much lesser when you have given preoperative bevacizumab as compared to a naive doing surgery.
So, sir, Rajiv sir, your inputs on that?
Yeah, I agree with Dr. Rajesh. I am using it still. I prefer, because definitely even the surgical plane, because of probably a bit contraction of the membrane, sometimes you get a good plane for dissection, easy to find the plane. And a couple of excellent videos, Rajesh, but just couple of things what you showed, the tug, a gentle pull or directly, or which you said that which caused a break. It's always better to do it at the disc rather than you went to the arcades and tried lifting it. Definitely there we assume that there will be a lot of pegs which are attached. So if you want to do this technique of en bloc dissection, or trying to lift the whole posterior hyaloid, again a gentle tug at the disc is something which is easier, and you get once you get the plane, then you can go ahead rather than pulling it to the mid cavity. That was one. And definitely, as he rightly said, bleeds are something you need to be careful, because wherever those pegs are there which attaches to the membrane, the blood tends to get attached there. So again you form a new membrane. So it's very, very crucial to use all your methods to the moment you get a bleed, try to clean it, or do some hemostatic measure. That's a very, very important thing.
I think, sir, Dr. Raju has some point to say. I think.
Yeah. Yeah, one question was Rajesh sir, when exactly would you give an anti-VEGF and when would you operate? Some people give the previous day and operate the next day. Some people give it for 3 days and they operate.
We prefer at 3 days time before. So we give on third day or fourth day we take for surgery. More than that, you don't want to wait because of fibrosis. Less than that, we have seen 3 to 4 days works pretty good.
Okay. And as you rightly pointed out, when you are dissecting these membranes, the vascular pegs come from below. So just reflect these membranes up and do the cautery before you cut them. That's what I do personally. Just lift it up and do the cautery and address the bleeds immediately. That's the most important thing that you should do. Never allow the bleeding to happen. Even if it is very little, stop your surgery, take your cautery, go and cauterize it, or whatever measure that you want to do, raise your IOP up. It will reduce your problems at a later point of time.
Cautery, I give minimum, because though it is an important tool, but we know that wherever you have cauterized it, sometimes it can cause a break there. So especially if it
Minimal.
minimal cautery, that is something on an.
Or you raise the pressure up.
Yes,
what I meant was to control the bleeding immediately, because if you leave it to ooze, then sometimes that itself becomes a big problem at a later point of time.
Yes.
I think, Dr. Rajesh, I think you are quite a very, very dexterous surgeon, and perhaps you have started feeling that after you give anti-VEGF, the plane demarcation might become difficult to appreciate sometimes because it gets stuck or something. That is why you have reduced the use of anti-VEGF. But personally, I would say, at least for people who are starting diabetic surgeries, better to use it. If you have a TRD, fibrovascular TRD, it does reduce that secondary bleed, and the secondary bleed management becomes a big problem. If you have a clean case, just vitreous hemorrhage, no problem. Go ahead directly with the surgery. And so what we generally do is, if you have a little bit of fibrovascular proliferation, we operate at 1 day interval. But cases which are bad, like the one you showed, which are a lot of proliferation, definitely wait for 3-4 days and then operate.
Okay. Jitendra, do you have any comments to make? Jitendra?
Regarding diabetic?
Yes.
It's a definitely very tough surgery, diabetic retinopathy.
And
but I just give anti-VEGF 3-4 days most of the cases.
Okay.
Just one message, Dr. Rajesh Guru, Dr. Mahesh Shanmugam, he always says that if you have a view of the retina, they are difficult.
Difficult cases.
So when you showed the first case and said that this is fairly simple case, actually, when a lesson should not go to the fellows who have, or the people who have just started. If you have vitreous hemorrhage, these are usually the better ones.
Better cases.
If you have, if you
is
can.
Dr. Salil there with us? Is Dr. Salil there? I think, okay, maybe he's left. And
actually, Dr. Khanduja, I explained the prognosis to the patient. He may have residual vision lost also after. This is most
you
important.
Can start
diabetic.
with 4/60 and end with hand movement close.
Yes, it's a possibility in advanced diabetic surgery.
I think that is important because you need to select which eye. Many of them, they have both eye disease, and that fact of the thing, you always don't try for the good eye first, because you cannot guarantee a better vision in that eye. Diabetic vitrectomies are really very you cannot predict that how the vision will be. You may do a very good job, remove all membranes, and vision may not improve. So I think always go for the bad eye first. That's, again, it's a variable opinion, but that's how I see it.
Yes. In private practice, actually, if you do the bad eye and the patient doesn't gain vision, then the patient will never come back for the other eye. So usually we also look at the prognosis part, and if we feel that we can give a better vision in that eye and we are confident of giving, I actually prefer to operate the better eye, or the eye with better prognosis, so that the patient gets motivated for the surgery next time around. But anyhow, as you said, it's an individual choice of how to go about in these cases.
Sir, any role of silicone oil you in diabetic retinopathy? How much silicone oil you are using?
How frequently do you use silicone oil?
Huh?
I think once you create a break, and it is like any other case. So if you can remove the membranes, the best scenario is remove all membranes, no breaks, no tamponade. That's the best prognosis. If you can remove the macular traction with, again, no tamponade is better. Even if you have left some nasal traction or superior, that is, the third comes if you have created breaks and put the oil. But definitely when there is a break, make it sure that there is no traction surrounding the break. So you need to make it sure to remove all the traction then.
Okay. So there was a question for Dr. Rohan. He said that how safe is PDT for subfoveal leaks in CSR?
Yeah, I wrote in the chat box, see, PDT is meant for subfoveal lesions and subfoveal treatment. But because of some cases which develop choroidal ischemia, may lead to a permanent central scotoma, we have started reducing the amount of dose or the amount of energy. So better to use half threshold, half threshold, or half dose for CSC, because CSC appears to be a mild sort of disease, responds to very minimal energy also. But
Okay.
when you are using treating a polyp or a CNVM, then probably a full energy. And sometimes when we have treated hemangiomas, we have even done a double spot. More
Sir,
energy.
we had a comment from Dr. Kamal. He said that in all eyes with blunt trauma, we should do an additional dilated fundus examination. I think that's a point very well taken, that to rule out occult retinal dialysis. And there was another question for Dr. Rohan, that when do you start eplerenone, and how has your experience been with this drug?
I think I would also like to hear other people's experience, because you see, eplerenone is a drug which is quite a bit in controversy. Initially, it came with a bang, everyone started using it, and then there were papers which said it may help, may not help. Even in my own, like I said, my personal experience, chronic cases, we have tried it and it does work in some. It's not that it just doesn't work. It does work, and now new research has come and which is showing that there are some genetic factors. People who have certain receptors, they respond. People who don't have, they don't respond. So for chronic cases, when you have nothing else, I would definitely give. Acute cases, it's a personal choice, and it depends on your conversation with the patient, how much uh, therapy he wants, how much you also want the patient to probably get something, and you feel it's safe. And it's quite safe. I've rarely had a patient with side effects. One or two have complained of muscle weakness, then I stopped potassium. I've never seen fluctuating. 50 milligrams, you start with it. I think it's not a big issue.
I agree, Dr. Rohan. Even so, in acute cases, usually I have not given, except for bullous CSRs, where you have the retinal detachment. And sometimes when you do an angiogram, and even in the sitting position, you are not able to do laser to these multifocal leaks. And these cases, I have tried eplerenone, and it works. Again, it's whether the natural history or the drug, but it worked well. Otherwise, in acute cases, I have not used. Chronic, our use has gradually increased, actually, much because of the problem of PDT. We don't have a machine and it has to come, and that limits the use many times. But at one time when we didn't had eplerenone, we had very good series of chronic CSR with PDT. It works pretty well. Somehow we do have these yellow laser. I have tried in a couple of them, but my experience has not been very good. And it's like neither patient feels nor we feel anything has been done. It never works for in our hand. So I don't have a good experience with yellow or subthreshold. But yes, eplerenone, I would say I've used in nearly about 65 cases, and pretty good results. About more than a third, what you said, about 50% of them in chronic CSR, it has worked. So chronic CSR, again, as I told you, evidence is very dwindling, and we really don't know, because there have been some RCTs too which have shown, but it needs to be taken for a long time. And as you rightly said, potassium has not been a worry. Never I had more than 5 value. Yeah.
So I think we finished with all the questions from the audience. I think, sir, if there are any more questions, Aditi ma'am, Rohit sir, Dr. Jatinder.
Hello.
Yeah.
Yes, ma'am.
Dr. Khanduja, with your permission, can I ask a question to
Yes,
Dr.
ma'am.
Rajiv?
Sure, why not, ma'am?
Yeah. And Dr. Rajiv, yours was really a star talk of the webinar. It was excellent. I think you did not leave anything in Brolucizumab. But I have a doubt, like what is the, how can we know that it is because of COVID? Because COVID is going to have a lot of occlusive cases. So the side effect of this Brolucizumab is occlusions in few cases, as you said. So how are we going to differentiate in coming times?
Yeah,
I mean,
I
it is
agree.
used in another 1 or 2 years in India.
So if it is after injection, by default, you will take that it is because of brolucizumab. You cannot attribute it to COVID, because you see, once we know that this is one of the side effect and you get it,
Yeah.
a patient gets it. Uh, I doubt you will attribute it to COVID, or I agree the COVID can cause, and no, you will take those history. Probably these are the cases again may have more risk, because they anyway have more chance of occlusions, and that probably can add up in one of the exclusion criteria in the initial stage.
So the rest of the studies are going to be held after a year or so, is it? In Brolucizumab?
No, there are a lot of studies. We are part of one. No, trials are still going on, and we are part of a trial of Brolucizumab for diabetic macular edema. We were one of the sites where we recruited. And the first thing I looked into once this inflammation came, that any of because we never knew whether we gave drug or aflibercept. Yeah. So that patient didn't had any inflammation. So we really don't know what we injected there. Okay. So there are trials which are happening. People are doing even now with a less frequent follow-up, trying to see whether we can achieve a better thing. And I'm sure Novartis will, and they are having a good team working on the side effects. And now recently people are talking about some neutralizing antibodies which are in the blood, and these antibodies probably are against Brolucizumab, and they form the immune complexes and cause all these inflammatory reactions. And they are trying to find out, can we have a blood test which can tell us that these are the patients who are at more risk of inflammation versus no. So I think it will find its own place with time. One of the things which I always feel that probably it may find a place in PCV in our country, because we do see a lot of it, and it has got a good sub-RP effect. And these are the patients who have much poorer vision. So probably people will start using more in PCV, and we can generate some good, from India, we may get evidence that it may work well.
But it also says that the fluid, it goes. There's no fluid after using this Brolucizumab.
You could see the Dr. Aditya OCTs were so good. Wish you had no inflammation. Everybody would have shifted probably by now.
Definitely.
Sir, but I think, but incidence is very low. Still, inflammation is less than 1% of the total cases.
The overall, what company claims is 1 in 1,000, and as Dr. Aditya was telling, that in India about 100 injections are given, and one had inflammation. So it's nearly about 1 in 100 in India at this stage. So we really cannot say. The problem is, even that incidence is low, you are a bit worried that you don't want a vein occlusion or artery occlusion. That's the main with a patient who has a posterior pole pathology.
That is the last thing you want.
Chalo, I think, sir, thank you everyone. And it's time for dinner. It's 9 p.m. Thank you everyone for joining in. Thanks to numerous.
Thanks a lot. Thank you everyone.
Thank you. Thank you, Dr. Aditya.
Thank you. Wish everyone a very good evening, and thank you for having me.
Sir, and very happy Diwali in advance to all of you.
Same to you.
Same to you, Dr. Sumit.
Thank you.
Okay, ma'am.
Okay. Thank you. Good night. Very good night to all of you.
Thank you. Good night. Good night, ma'am.
Good night, sir.
And a nice interaction with all. Bye.
Thank you.
Dr. Khanduja?
I think ma'am, he is gone.
अच्छा me ऐसा चलो यहीं रहो, be there. I told him that we can have a group picture in the end.
Okay.
So we have a recording of it, but still he has left. Khanduja has left. It's you only who's coming, Jitendra.
Dr. Raju is also there, no?
Yeah, Dr. Raju is there. It's nice to have Dr. Raju every time we are there. In Karnal Society, he presented in HOS. It's always the same.
And you like our presentation?
And your experience of photography, basically. The smartphone photography, I really appreciate that.
Yeah, I use mirrorless camera.